Good afternoon, dear colleagues. Good afternoon, everyone. I'd like to start my presentation from the definition, which all of you know well, to highlight how comprehensive the system has to be, which will be developed to cover all the aspects of mental health according to the WHO definition. Let me start my presentation from the economic aspect of mental health, from the saying that on average, according to the calculations of the developed countries, the losses due to mental health problems are about 4 to 5% of GDP annually. And here I'd like to highlight that we speak about the losses which are calculated, which were calculated for the developed countries without the war. So the losses that will be in Ukraine and are in Ukraine will be bigger. No one has been through this experience or a similar experience in the world. And moving on, I want to say that despite the fact that we don't observe the epidemics of the mental disorders, I mean, annual increase of all the mental disorders is about 0.3%, but during COVID-19 pandemics, we've seen significant increase due to the depressive and anxious disorders and also anxiety disorders and also other disorders. And also I have to say that due to the fact that from 2000 till 2022, the developed countries started using more psychological and low-intensity services. Due to that, the system effectively coped with the pressure, which was during that period of time. Comparing it with the data we have in Ukraine, the use in Ukraine is about 8 to 10% of the psychological services. The level is way lower, and it's related to the fact that in the developed countries, there was huge psychological campaign on psychoeducation and destigmatization, and a lot of services were created which increased the accessibility of the service. According to the WHO data, it is forecasted that as a result of the war, we will see the increase of light and medium mental disorders from 50 to up to 100%, and there will be an increase by 50% of severe disorders, and there will be more people come into the system that will increase the number we see right now. Also, examining the service users, system users, we analyzed different sources. Firstly, sociological research is conducted during the full-scale invasion by the Russian Federation. And also we used the data and insights which we received during the conduct of the strategic session. And also we used the methodologies of international organizations and data from different scientific publications in our work. As a result of our analysis, we've identified that at least 50% of the population of Ukraine goes through the potentially traumatizing event by different categories. Firstly, people in the deoccupied territories, citizens who live who are the first responders, externally displaced, internally displaced, military men, veterans, unemployed people, taking into account all the age groups, and all these citizens will need psychological aid of different intensity. Also, this number may increase potentially. Speaking about the target populations, here in this slide, we researched and examined their needs and assessed their needs, and you can see it in the slide for both for IDPs. First of all, those needs related to relocation and the perception of them in the new location. In this slide, you can see that mostly we will face depression and anxiety disorder and substance abuse among the people of this population and population group. The second population group, which is also important, the military men and the veterans, who also face the listed on this slide problems, firstly related to their different status and the changed patterns of socialization. For them, it's also usual to see depression and anxiety disorders and substance abuse and PTSD in level increase. Also, the elderly people, this is a vulnerable to social isolation category for whom there will be an increase of depressive anxiety symptomatics, and special attention should be paid to, first of all, dementia and related to it other mental disorders. That's why it has to be paid attention to. And the other target group is teenagers, among which we also have to pay attention to anxiety and depression disorders, and the work with suicidal behavior, work with substance abuse, and the behavioral disorders, deficiency of attention and hyperactivity, as you can see it in this slide. The citizens in the deoccupied territories, in contrast to other groups, there aren't so many of them, but they have specific needs, which you can see here. So it's also usual to see depression and anxiety disorders and substance abuse among them, and diagnosed PTSD. These groups, which cannot be excluded from the attention when we develop different services, I mean the police and family doctors, I mean first responders, state emergency service, state teachers, the workers of local authorities, railway companies, mothers with children, and people with severe mental disorders on hospitalization. All of these populations also need special attention during the development of services. We also forecast the increase of the load on mental health and psychosocial support system up to 5 million new requests, and that's about 70% of new load. We speak here about specialized aid, but also about 3 million citizens who can receive aid on the second and third level. I mean psychological aid of low intensity, psychosocial aid. 2 million citizens will need specialized aid, and 18 million citizens, this is the category of distress, and this is the category of people which can cope with their problems using the self-help resources and mindfulness resources, and asking for help, calling hotlines and support chats. Here you can see the slides. I will not spend a lot of time talking about them. Here you will see the brief summary of the audit of the system resources that Mrs. Oksana has mentioned, and you will hear more about it during the next meeting. Here we see how many citizens are overlooked by the two blocks of the system, medical system and social system, and that the need in this area is unmet. And also the analysis of the international experience and building of the system, which can, and the elements which can be used, and when we adapt this experience to Ukrainian realities. Analyzing international experience, we focused both medical and economic analysis using two big frameworks. First of all, comprehensive, the WHO plan on mental health, and OECD framework. And also we have identified 6 points of analysis: the personal, users and needs, quality, stigma and services, which we studied in details. As a result of this analysis, we have identified 3 main elements which need to be implemented. First of all, to build an effective system of mental health based on the experience of the analyzed countries. First of all, this is the integration of existing medical, social, and educational services into the one network. Also, it's about strengthening and creation of the new services on the primary care level and in the community, and the creation of the culture and providing the resources for self-help. Implementing these three key points, we can receive the segmentation of the users, which will be similar to the one that you can see in this slide, just like it's been realized in Australia, when most users can cope with their own needs on the level of self-help and psychological aid, and only 8% of users will need specialized treatment, and only 3% will need specialized treatment in the inpatient departments. The system, which will be designed based on the experience of Australia, Great Britain, and all the analyzed countries, first of all, has to be needs-oriented, oriented on the needs of the users, and it has to include four main elements: the focus on early interventions, the solution of different social and economic determinants of mental health, because if you remember in the previous block of the presentation, these needs are always the priorities among all the users groups, and they have to be always in the focus when we design services. And if these needs are not met and taken into account, the services created in the mental health area, in the mental health system, may not be effective enough, since social and economic factors are an important determinants for mental health. Also, the services have to always be accessible according to the needs. It's stepped care approach. Also, it's important to keep in mind the psychosocial component and the inclusion into the society, despite the level of the needs and pathology. This is the psychosocial services, which have to be on all the levels of the pyramid of mental health services. And to create the effective interaction, which is the key point out of three identified ones, we have to join and integrate the current and existing system services to create the bridge for interaction between medical and social services, which already exist in the country, and to implement three key roles: the coordinator of the network, the case manager, and clinical psychologist. Let's hear more details about it. Given the example of how the system of integration of the services in the area of mental health worked in Belgium, we have the network structure, which is realized through main 5 functions. And the most important thing is for the elements of every function to be effective, thanks to the WHO, Ministry of Health, and partners, and all the other stakeholders. All these elements function, and the next step is their integration and interaction and referral, and the creation of a responsible focal point, both on the regional and local levels, as the coordinator of the network. In terms of the interaction between social and medical services, we speak about the experience, first of all, of the UK in the practice of social prescribing, which enables to decrease by 27% visits to family doctor and to specialized services by 20%. As we know from the researches published in Great Britain, 20% of the patients who go to their general practitioner, they come to him mostly due to social issues. To create the good quality services on the primary care line, it's important to take care of the service providers. The example of Belgium shows us that this quality may be implemented due to clear identification on the legislation level who can name himself or herself, or be named a psychologist or a clinical psychologist? What is the way from the beginning of the education to the beginning of the practice for the psychologist? And first of all, for the clinical psychologist who can work in the system of mental health in the medical line due to licensing and certification and due to being in the open registry of service providers. That's a good example which may be useful for Ukraine. Going back to the bridge between medical and social services, I'd like to attract your attention to the fact that it's identified with the help of case manager, the person who is responsible for the integration of the services in the community, which are already available into the one network and referral of the client from medical service and other services according to the needs of the client. It may be both a social worker who can do it, who received extra training, and also it may be a person without special education, but who complies with the list of soft skills, because this is the work which is all about communication. The implementation of this role and this bridge enables to reduce the non-target visits to the system and to connect the people with the existing services in the local community. And this way, it will improve the people's health and well-being. When we create the new services, we have to take into account the existing experience of standardization of the services in the area of mental health and the current mechanisms of co-funding and the creation of the service market, identification of the target groups when we develop the services, the priority target groups, and joining not only offline, but also offline and online services. So speaking about the standards of operation procedures, we speak about token services and IAP services. In the Great Britain, this is accessible psychological aid for different mental disorders, which works according to NICE protocols for the most widespread mental disorders, which are clear, specific, and there is the list of the service of disorders this service works with, and the protocols and the special systems of trainings and supervisions are developed for that, and also the routine monitoring of quality results of treatment works in terms of getting better or not getting better, and the assessment of the quality by the user, which enables to create the transparent and good quality service. In terms of the mechanisms of co-funding, here you can see the Belgium experience in the provision of the experience of co-funding of psychological services on the primary care line. Here you can see two packages on this slide, which are paid by the patient. In 15% is paid by the patient. The first consultation is free of charge. The emergency aid is free of charge. And this way it balances the demand and capacity of the system. And on the other hand, it makes the service affordable for the population. Joining the services, first of all, in online services. Here you can see the Australian experience and the service Head to Health, which is at the same time a huge online catalog of low-intensity services, 756 resources. There are methodologies of self-help and simple services to provide low-intensity brief interventions, which are mapped and put on this resource, and also the network of offline centers, which are responsible for coordination and referral of the users inside the system and to the specific service according to the needs of the user. As I've said earlier, the teenagers group is a very important target group, and it has to go separate, since we know from the international literature more than 60% of the mental health disorders start in the age before 25 years old. And according to Head to Health, both offline and online networks, focal points for this group increases their visibility for the system, and the number of appointments, and this network is really big, 145 centers, and the portal with the self-help resources and possibility of short consultations, both psychological and educational. Also, it's important to say that child population is very important. As the example of different countries, we can see basic psychosocial skills and resilience skills are included from early school age in the form of extra classes, and it has proven positive effect to psychological well-being, resilience, and the development of necessary skills from early age. An important point which has to be taken into account, since for Ukraine, as you can see it on this graph, the point of suicidal prevention is actual, even comparing to the reference countries and the countries which were in the focus of this analysis. The really important group during the work with the suicidal behavior is the military men, veterans, and men in general, because suicides in this category are committed 6-7 times more often. We already have the ready methods and practices which have proven to be effective in the prevention of suicides, and the WHO has represented the approach to the realization of the policies in all the areas. Live life. They are shown here on this slide. Also, the target programs have been shown implemented in the Israeli armed forces among the military men and veterans of the USA, with the aim to reduce the level of suicides among this group of people. Also, it's important to say that the creation of culture and trust is important. Firstly, it's about work with stigma and strengthening the participation and responsibility of the service user. In terms of stigma, we use the UK experience firstly, since over there one of the most anti-stigmatization campaigns, one of the biggest campaigns has been conducted from 2007 till 2020 has been conducted. It was multi-vector. It had media component and activity in the communities, trainings, and the development of different educational content. The most important thing is that the result of this anti-stigmatization campaign was proven to be effective in a lot of clinical researches, as the results of which you can see on this slide. And also, this program has the experience of globalization, and it was realized in India, Uganda, Kenya, and also it had positive results. It had positive results in terms of engagement of people with mental disorders. Here you can see the experience implemented not only in Australia, but in all the systems we studied. During the Belgium visit, we had the possibility to communicate with the representatives of the patient organizations and their caregivers, and we received the direct contact with them and information about how it strengthens their role in the system. Also, we can see here that they may be engaged both on the individual decision-making level, I mean, when they jointly create the treatment plan and they have the possibility to give the feedback and the possibility to receive the information on their mental health and mental disorder, and on the level of design of implementation of services, policies, and the selection of sectors where the system develops. It's important not only due to strengthening of the user's role and their caregiver's role in the organization, implementation, and service quality assessment, but it also gives more responsibility to the users, which enables going from paternalistic to partner relationships in the mental health system. Also, I want to finish my presentation saying that we focused not only on the successful stories and experience on what it worked, but also we focused on what has to be avoided during the service design and when we create new services. So You've paid attention to the fact that the presentation wasn't focused on the specialized aid, because out of the experience of other countries, out of the information that has been already elaborated by different teams in different countries, we see that this process has to be, first of all, comprehensive, gradual, and it has to be started after the creation of enough number of alternative services in the communities which can meet the needs, which will be actual, relevant during this change and transformation. Also, it's important and clear from the experience of Belgium and other systems, it's important to have a separate team responsible for the formation, since it's a long-term process. On average, most reforms which were assessed, they started and they still continue working from 5 to 20 years. These changes are constant, are standing, and it's important for the team who manages this reform to provide the clear horizon of the reforms and to avoid the fragmentation of the changes that will enable to receive the results on the implementation of new services and changing the existing services. Also, it's important to emphasize that the donor funds may be a great catalyzer to create new services and to reorganize existing services, but donor funds, this process has to include transferring to the market of service providers, because target funding is on the one hand a significant push for development of something new, but on the other hand, it may be the risk factor when the program finishes, the service may simply disappear or may lose its quality. That's why the transition plan and the development of the service market is really important. It's also important to take into account the experience of Australia and other systems which have huge investment into the health system, and which created a lot of different services. But without clear system of coordination and referrals in between the existing services, adding new services into the system does not reduce the load, but sometimes even creates more confusion than before the services were implemented. And as a result, the service users still go to the wrong service institution, not to the one that meets their needs, but to the one which is clear and familiar for them. And the new services do not meet the problems they were created for. I think that's it from my part. Thank you for your attention, and feel free to ask questions.